recognizing severity. You know, we're using that visual inspection, your probe depths, your clinical attachment levels, your radiographs, all those things go into identifying and recognizing the severity of the disease. So that's kind of the initial determination that we need periodontal treatment, right? So you've done all these assessments, and now we know that we need periodontal treatment, right? I don't know why this is playing this voiceover, and I don't know how to make it stop. Just mute it. Okay. Some of the diagnostic methods. So we talked about having these adjunctive, or they are adjunctive methods, and it's combined with your clinical examination. So you're gonna have to do clinical examination regardless. That lets us know that there is periodontal treatment needed before something like any of these things that we're gonna talk about today would be done. But it does help to identify that periodontal disease activity. It helps to identify patients who are more at risk for an episode of activity. Helps us to determine the appropriate mode of treatment. Again, if there's a certain bacteria that's involved, we can, spaces this morning are killing me. Anyway, helps us to determine what type of treatment that we need to do, and then of course helps us to evaluate as we go through time and future periodontal breakdown. All right, some of the tests that are used helps to, of course, evaluate the periodontal disease. There's 3 different groups. So you have the gingival curvicular fluid assays, microbial tests, and then there's genetic assays. So we're gonna kind of go through what each of those are. Gingival curvicular fluid is the first one. Of course, that's one of 3 most common oral fluids. And we know that that originates from that connective tissue, and it flows into that gingival crevice, and it's going to be higher in times of inflammation, right? Because you have those the fluid is leaking from the dilated vessel. So when the vessels dilate, there's more fluid in there. And that fluid collects that breakdown of all those enzymes and everything, and they kind of have termed that inflammatory soup. Kind of sounds gross, but it's just a mixture of all those things that are in that gingival curvicular fluid. And by measuring those, we can determine if periodontal disease, or in the progression of that is, that they use that as determining for a marker of periodontal disease. So we can measure that gingival curvicular fluid, and that's kind of what we're talking about. This should be a little bit of a review, that you have those different layers, and the lamina propria that's down here on the bottom is where that gingival curvicular fluid is kind of originating from. So how do they get it? It's basically like a little paper point, a little paper strip that's placed into the pocket, and it is collected onto that little paper strip. So there's host-derived enzymes. Again, some of this stuff should be kind of a review from last year. Not last year, earlier this year, I should say, last spring. But we know that those certain enzymes are associated with increased risk of clinical attachment loss and bone loss. Again, they're markers for periodontitis, so when we see those, we know that there's a risk for periodontitis, and they're most evident they can be more evident up to, there's something flying around, 6 months before, y'all, I'm being attacked by something up here. 6 months, sorry, squirrel. 6 months before disease actually occurs. So that's kind of interesting that it can actually start that far in advance. Those types you should be familiar with, but kind of commit those to memory as far as seeing those again. You will see those again, so you want to be able to pick anything out that's not on that list, okay? Okay, these top 2 here are some other enzymes that would be inside of that inflammatory soup that we're talking about, and that helps to predict clinical attachment loss and bone loss. So if they're using these little gingival curvicular strips, and we have those are some other enzymes that we know that that's going to be higher periodontal activity. Also, the AST was on that list. That is an intracellular enzyme, and that being there lets us know there's cell death. It predicts clinical attachment loss also, and that one can, on average, be 3 months in advance. This one though, that says there's no test available commercially, and I've never worked in an office where we've done these. I imagine more perio offices, but I do think some of these detection methods are becoming more popular. You may work with a lot of periodontal patients or in a periodontal office where they actually do these. So it's just something to be kind of aware of that's out there. And then that last one, that last enzyme, collagenase, it's normal collagen remodeling through the breakdown. And then when you have excessive amounts, lets us know that there's tissue destruction there. Prostaglandin E2, that one is specifically associated with bone loss, so that one's important to remember. Those levels are higher in patients that have periodontal disease, or that CAL is higher than 3 millimeters. It's going to be higher than people who do not have any CAL. Higher levels indicate an increased risk of periodontal disease 6 months again prior to the appearance. All right, the second type of test, so we had gingival crevicular fluid assays. Now we're looking at microbial tests. Bacterial plaque biofilm is what's being tested. The periodontal pathogens associated with those, there they are that we just talked about, with that top one being AA. Again, we know that those specific types are documented to cause periodontal disease, so if we see those, then we know that this patient has a higher risk, of course. Identification allows for faster and better treatment. It's aimed at eliminating or reducing those bacterial levels. So a lot of these tests, I mean, this typically I wouldn't say are probably done on every periodontal patient, because some patients respond very well to periodontal treatment. You're going to notice some of these are more specific for those refractory cases where they just are not responding, and we, trying to figure out what else we can do to help. Some of the methods for testing. Have you ever had, or did any of you? I'm sure you've had a culture lab where you culture something at micro, right? So similar to that. So you have that culturing analysis. There's microscopic techniques that are used, the nucleic acid probe analysis, and then the immunological assays. We'll kind of go through those a little bit here. So the culturing, again, that should kind of look familiar. It's a similar process, but that allows whatever bacteria is there to grow, and so that they can see exactly what's under what's actually growing in there. The technique, they just removing that biofilm, the sample's taken just with the curette, just taking it out of the pocket area with the curette. Samples placed in transport fluid, sent to a lab, lets it grow to determine what's there, so that then they can actually target that particular type of bacteria. Again, these are more of a lack of response from conventional therapy. And then we can determine the type of antibiotic that's needed based on the type of actual bacteria that's there. And you don't necessarily need to know exactly how that's done, but just when you're looking over, you can kind of look over that slide, but basically the patient's kind of rinsing and spitting back into that little collection tube, and that's how it's transported. And that one was with the oral DNA. Sorry, the first one was with the curette. All right, microscopic techniques. There's phase contrast microscopy, and then the dark field. The phase contrast is just going to let you identify the bacteria based on the motility that's there, whereas the dark field lets us see which type of bacteria based on shape. So you kind of use those to give our patients more, oral hygiene and educate them on what's going on. The nucleic acid probe analysis, so this one's specific for DNA, and we talked a little bit about how genetics and DNA play into periodontal disease. Our DNA, of course, have a very specific sequence to it, and it's unique, and not only ours, but bacteria do. So they can use that, to determine which type of organism is there. The nucleic acid helps us to identify that DNA. Sample collection is very similar to the first one that we looked at, where just a little paper point is put into the pocket base, and then it's sent off to the lab in a vial. Once they get it to the lab, they cut that DNA. That probe there's actual probe that's made for this. It's labeled with a radioactive or enzyme marker, and then that binding occurs and it helps to identify the actual organism that's there. And these have pretty quick turnarounds, so within 24 hours they can identify that. They're used specifically, again, for refractory cases that don't respond to conventional treatment. Helps to determine the type of antibiotic that would be needed, to monitor the therapy outcome after disease is controlled, and then evaluate any implant sites. All right, the immunologic assays, there's one that's specifically called ELISA, and that's an enzyme-linked immunosorbent assay. Specific binding of the antibody to an antigen on the surface of the microorganism that's collected. This one is probably only used with more like research type situations because it is an expensive test. It's just something to be aware of. All right, and then the genetic assays you have, of course with genetics, we know that that's a risk determinant for periodontal disease. That's a non-modifiable risk factor from what we talked about last week. Interleukin-1, you have the cytokine that's produced and secreted by inflammatory cells, and those are responsible for inflammation. And then you have the IL-1 genotype, production of too much of that in response to the bacterial insult. And then it predisposes the patient to disease processes and occurs in about 30% of the population. So 30% of the time you're gonna have that IL-1 genotype available. Testing for that is basically saliva based, so it just determines whether they have that genotype. The patient's saliva is collected, it's sampled by the lab, and whether they're positive or negative kind of lets them know whether or not that patient is going to be more at risk. People who have this genotype are 7 times more likely to develop advanced periodontal disease, so that's how that works as a non-modifiable risk factor. All right, some specific aids that are available dental hygiene wise. A lot of you already have some of these. Of course, we know certain things like loops and things like that help go to your ergonomics, even though some of you I still see with loops are still like this, which is completely just goes against the whole purpose of them. So try to keep that in mind when you're working. But it helps increase your visual field and decreases muscle pain and eye fatigue. There are endoscopes that are out there that are used to help, actually I've seen these used more with like root canal therapy and stuff like that. Any of you, I know some of you work in offices, but I don't know if you've ever seen any of these big microscopes before, but they're kind of cool. But they can be used for periodontal treatment also. Loops, like we mentioned, magnify, that can go up to 6 times. Most of yours are probably the 2.5, sometimes the 3.5. Usually for hygiene, we don't need a closer field than that, but they can go up to 6 times magnification. Of course, we know they're custom fitted, and based on weight and adjustment of those loops. There's also microscopes that are used. Again, these are similar, like what I was just mentioning. You have the endodontics and restorative, that those are more common for. The guy in that picture, that's what he's using. I've seen those are actually big, like they roll over type big microscopes that are used. Cost versus benefits, it does improve access and get better clinical results and better ergonomics when those are used. Lasers, can't remember if we mentioned it in here or not, or if you guys have seen any of the things that they have passed laser for us in Georgia, so hopefully before too much longer we'll have that, where you'll have a certification for that, just like you do for local anesthesia. But it's not a substitute for treatment. It would be used as an adjunctive. So somebody who had periodontal treatment, the laser can be used as an adjunct for periodontal therapy. I have worked in offices that have this. It's just in Georgia up until recent, of course, we can't do it ourselves, so the doctor would have to do that. But it does help to remove that soft tissue which is in the pocket. So they would use this after periodontal treatment's been done. They go back in the pocket and kind of help to remove that diseased tissue. It helps with coagulation, so it helps stop that bleeding. There's less swelling and discomfort. Subgingival bacterial reduction occurs when lasers are used, and it kind of helps to sterilize that pocket. There's soft tissue lasers, so those are the different types of lasers that are there in the colored words. They are well absorbed by melanin and hemoglobin, and of course there's different wavelengths that are used, so even though there's fluid in there, it's helped to be transmitted through the water that's in the fluid. Usage, again, laser energy is transmitted through that fluid in the sulcus. It's most attracted and reactive to diseased tissue, so that's the tissue that it's gonna be most effective for. Patient population, you know, they again use lasers for lots of different things. They're gonna be used probably by you for periodontal treatment, but I don't know if you guys have ever seen anything, or we talked about getting those ulcers and stuff. I think some of you mentioned you sometimes get those aphthous ulcers. They have actually been able to laser some of those areas, and they supposedly will not come back in the area that they laser. So somebody who gets frequent aphthous ulcers and stuff, these are, I mean, it's not something that you would be doing, but it's kind of interesting to know that you can laser those areas and then it doesn't come back in that area. There's improved healing with lasers. There's probably much more research now than when this was first created, but they are showing a lot of positive results with laser use. And it could be harmful, of course, that's why you need training to do it. It could be harmful if you're not using the appropriate power level. They have to be calibrated. The actual machine is calibrated. Maintenance, they have to maintain a contact with the actual target tissue, and it helps with that inflamed epithelial lining. That fiber is placed at the top of the sulcus, and then laser energy is kind of directed away from the tooth structure. So again, not something you have to know how to use, but you probably will see it in your time. And then they just kind of use it similar to probing. I mean, it's kind of walked around the tooth like probing, but it's an actual laser that's in there. So fresh bleeding equals completed bacterial reduction. So that's what they're kind of looking to start that fresh bleeding process. The energy's changed to coagulation setting. That fiber contacts the tissue, and it's just, again, those repeated motions until the bleeding is stopped and then the therapy is complete. So there's, you know, different time per site is determined based on the periodontal involvement. Of course, it would probably be a little longer for more periodontally involved sites. All right, post-op instructions. Analgesics can be used if it's needed, so, but it's not anything more, you know, painful afterwards than the actual SRP treatment is. So ibuprofen or acetaminophen would be fine. But these are things that you probably are telling your patients anyway after you've done SRP, is to take those. Tell me what some of the things you should be telling your patients after they've had SRP. We know they can take ibuprofen or Tylenol. What else? Do y'all tell your patients anything after? Just go home and see you next time?
Switch with salt water.
Warm salt water. I always tell them to use warm salt water. What if they notice a lot of bleeding? What can they do at home? If they feel like the bleeding in an area hasn't stopped, do you have any recommendations for that?
Get a tea bag.
Tea bag or very, you know, what do they do with it?
Put it around the gums.
Yeah, they can kind of put it in place and close down around it and leave that there. That helps with the bleeding. To avoid certain food types, I always tell patients, because you've removed, especially patients who have a lot of calculus and stuff in there, their tissues have been, you know, tighter around that calculus, and then you remove it, so there's a space now. It's kind of, you know, sometimes you have that kind of floppy tissue that's in there. So if they go home and eat a bunch of popcorn and chips and stuff like that, what's gonna happen? That stuff gets trapped up under the tissues as it's healing, and then that you can cause abscesses and stuff. So I try to tell them to avoid stuff like that for a day or two. Don't go eating those little tiny seeds and popcorn and anything that can break and get down in there. You wanna keep a soft, probably neutral kind of diet, nothing too spicy. Anything else you can think of post-op? To do what with it?
Avoid alcohol and smoking perhaps.
That's a good one. Yeah, avoid the smoking for sure. Patients that you know smoke, you want to have them not do that for a few days if possible. Most of them probably are not going to listen to you, and they're going to go do it anyway. But and then of course just documentation of the use of, laser would be appropriate as well. Let's see, probing afterwards. So once patients has had laser, we don't wanna go right in and probe. So there's kind of a 3-month post-op therapy for that, and of course, definitive reprogramming after that 6-month period. With healing, just like we've talked about with other things, it heals apical to coronal, so. Dental uses, so again, it's not just for periodontal therapy, but lasers are used. There used to be something called, or there probably still is, but we don't have it anymore here. But it was called Diagnodent, but that was a laser use that you could actually use that to check pit and fissure caries. What I'm talking more about has been with the soft tissue, but they can do gingivectomies with that. Y'all know what a gingivectomy is, or when somebody would need one of those? I know we haven't talked about it yet, but that's a good example. Somebody who's got a lot of overgrowth with braces, sometimes they will take those off, and that's a good warning to these young kids when they have braces and you're seeing that they're not doing really well. You can tell them, you know, your tissue can get overgrown. I've seen it grow right over the tops of brackets, and the only way really to do that, you know, to kind of get rid of that and heal that up is to go in and do a gingivectomy, and they can do that with scalpel, but they can do it now with laser too, so that's good. But they use this for caries removal and cavity preparation also. And these are just, I mean, they, of course, depending on the brand, are gonna look a little bit different, but uses again for that type, that NDYAG, I'm not really sure there's a way to say that other than just say the letters. But uses are gingival curettage, the gingival incision and excision, like we just talked about, gingivectomy, and biopsy even. There are newer systems. These are not FDA approved yet necessarily, but just something to be aware of, that they may be becoming, once they may be becoming popular once they do get FDA approved, but it's called PerioWave, and that's just a lower power diode laser.